Thank you so much for joining us. I'm Celina Yong. I'm an associate editor at JACC, and I have the great pleasure today of talking with Dr. Eric Cantey, who is an assistant professor at University of Michigan and also the associate director of the BMC2 PCI registry. Thank you so much, Eric, for joining us, and congratulations on your manuscript that is going to be published in JACC alongside your upcoming presentation at ACC. It's focused on current practice patterns in the care of acute MI cardiogenic shock, and very timely given the recent introduction of the danger shock trial into the ACS guidelines. I was wondering, Eric, if you could just start by sharing with us your rationale for the study and a brief overview of what you found.
Great. First of all, thank you so much for having me and allowing our work to be highlighted from the BMC2 registry. So this work came out of really out of the post-danger shock era. So as we know, acute MI cardiogenic shock occurs in about 8 to 10% of STEMI patients, and it carries a pretty high mortality, around 40 to 50%. And prior to danger shock, there really was a lot of effort with not a ton of traction of really moving the needle on that mortality benefit. So in the post-danger shock world, which compared microaxial flow pump to routine good ICU care, we really thought, how do we implement, or how do we start to look at these findings and translate them into clinical practice? Data also from your journal, from the C3TN database, showed that approximately a third of patients really met the criteria for the danger shock inclusion/exclusion criteria. So with that, we wanted to look from the BMC2 registry of what does the care of these acute MI cardiogenic shock patients look like in the real world. So that was really the rationale for the study, or for our analysis itself. So a little step back, the BMC2 registry is a quality initiative within the state of Michigan to improve and enhance the quality of PCI. It's built off of the NCDR registry, and we have pretty rigorous auditing of the data to ensure its data fidelity. And it includes about 50 non-federal hospitals, and track a variety of outcomes within the NCDR CAP PCI registry, but also some other variables for quality improvement. We strove to create a danger shock-like population and mirror the danger shock inclusion/exclusion criteria to look at both the incidence, or the prevalence of acute MI cardiogenic shock within the state, and then looked at it on a provider level and an institution level. And what we found was threefold: is that one, the prevalence of acute MI cardiogenic shock is low at each institution. Two, the average case volume for the average interventional cardiologist in the state of Michigan is low. It's around less than one case per year. And then finally, we found that there was significant heterogeneity in the treatment of patients with acute MI cardiogenic shock.
Thank you so much, Eric. There is so much to discuss here.
Yes.
So let's start with one question about a finding that you showed, that microaxial flow pump use was actually not correlated with AMI cardiogenic shock volume. What do you think may be driving its use, if not case volumes?
Yes, so I think that speaks to one, the key findings of this is that there's significant heterogeneity in the care of these patients. And the pre-danger shock era, there wasn't really consensus on what the appropriate treatment for these patients was. Was it hemodynamic guided? Was it what your institution was comfortable with? Or was it what the interventional cardiologist or the critical care doctor was comfortable with? So I think that showed that there was not consensus prior to the danger shock trial of what we should be doing for these patients. Also, to dovetail off of that, I think one of the things we can also discuss is we also looked at the use of right heart catheterization to guide treatment decisions. We looked at concomitant use of right heart cath at time of MCS implantation, and we found that only approximately 1 in 3 of patients who had defined acute cardiogenic shock underwent right heart catheterization at the time of NCS implantation. So this leads to, I think, a lot of work that needs to be done in this field of one, really streamlining care. By that I mean recognizing acute myocardiogenic shock, phenotyping patients early, determining are they actually in a low flow state? Do they have the hemometabolic profile found in the dangerous shock population? And then 3, early support. And then 4, a whole part of this is managing the patients after device implantation. And I think that that's really where in the dangerous shock trial, where approximately 1 in 4 patients had a device-related adverse event, that is really where the risk mitigation and the management is really critically important for these patients.
That makes sense. I think many people might be shocked to see the low median case volumes that you present per site and also interventional cardiologist.
Yeah.
And I wonder, now this is a little bit beyond the scope of your manuscript, but do you think that the case volumes are necessarily related to directly to the outcomes? And I realize you have to divide this, from the procedural perspective versus the post-management, because, we're probably seeing part of the picture here. I mean, the operators who are doing these procedures are presumably also doing these same exact procedures in other patients for other indications, like
Yes.
microaxial flow pump for high-risk PCI and, large bore access for structural heart. And so how do you think the case volume relates to necessarily the need to transfer them, or do we take a more nuanced approach to our strategy for their management?
Yeah, I think you're highlighting on a critical issue here, and yes, microaxial flow pump is used in other indications, specifically high risk PCI, but I don't have the specific data to really point to does in our consortium, because we were not able to control for all the specific variables that led into the actual treatment decision. But I do think that your point is valid, is that we do need to start standardizing, really focusing on shock protocols for one, recognition, 2, the safe implantation of these devices and the appropriate aftercare of these patients. But I think it speaks to the fact that if these patients are there as a state, our numbers are high, but on an individual hospital level, they're low. How do you start to translate these findings to make sure that the one time a year, the interventionalist is placing a device in this specific circumstance, that it goes in safely, that the cath lab staff is ready to support the case? And then finally, where does when the patient goes to the ICU, do they feel comfortable with managing the actual device? I think it also speaks, and I think what you're also alluding to is hub and spoke models. We are not advocating that all of these patients need to be transferred to a tertiary care hospital. But I do think what we are advocating for is that there's a specific skill set and comfortability that interventional cardiologists who are taking acute MI call, we should feel comfortable as a community recognizing the patients, supporting them, and then if the hospital does not have the resources, to be able to escalate therapy as necessary. And I think that that's an site specific and frankly provider specific response.
Thank you. Maybe we could talk about danger shock for a moment.
Yeah.
And, it was completed entirely in Europe, and of course, very different healthcare system than we have. And when we talk about hub and spoke, aside from like the VA healthcare system in the US, we really don't have a easy way to set this up. And it's a real challenge in the US. I wonder if you can share some of the biggest barriers that you think we have to moving towards something like this, if you think that's appropriate.
Yeah, I think that individual systems of care are critically important to this. And what we are experiencing in the state of Michigan may not be applicable to more population dense areas like the East or West Coast. But I think the key thing is that this involves a village, and this involves all of the key stakeholders. And within the BMC2 consortium, we are starting to engage with the key stakeholders, and it's not just interventional cardiologists. It's creating a group of intensivists, emergency physicians, and interventional cardiologists that can collaborate and learn from each other. And with that, we can start to tease out what are the nuances of a hub and spoke model. I think with individual institutions and individual organizations or health systems, I think that is a critical part that needs to be sorted out. But I also think in the end, we're all doing this to help patients, and we're all, frankly, doing this to help the sickest patient that you're probably going to see on your acute MI cardiogenic or acute MI call for that year. And in the end, I think it's all about the preparation and the collaboration with key stakeholders, and then finally leading to education so that you have repetition and that you have the continuous reps to make sure that when you are ready, it's not just you, but your ICU is ready, your cath lab staff is ready, the nurses are ready to really care for these critically ill patients.
Thank you
Great.
so much, Eric.
Of
It's a
course.
pleasure talking with you. Thank you so much for
Yes,
your insights about this, and
I really appreciate
congratulations.
it. Yeah, thank you so much. I really appreciate everything.